All right, today we are going to be doing the psychomotor skill of inserting an NG tube, irrigating an NG tube, and then for psychomotor you will either do feeding or medications, and then everyone will also remove the NG tube. So we're going to first start by inserting the tube, which is probably the most exciting part. So before I get started, I'm going to walk in my patient's room, wash my hands, introduce myself. So, hey, Mr. Smith, my name is Lauren. I'm your nurse today, and the doctor has ordered for us to put an NG tube in for suction. This is going to help decompress your stomach and make you feel a whole lot better. Before we get started, I just want to explain kind of how this is going to work. So I'm going to put a tube in through your nose. You're going to swallow. That's going to help me get the tube where it needs to go, which is in your stomach. The more you swallow and kind of work with me, the easier the tube will be to get in place and get into your stomach. So I'm going to have kind of a companion here helping me with a cup of water that you can sip to kind of help with that swallowing process. If for any reason during this skill you're in severe pain, you feel like you can't breathe, if something feels wrong, I want you to raise your left hand to indicate to me, even though you don't have left hand, but to indicate to me that something isn't right or doesn't feel right, okay? That should not be the case. This should go pretty smoothly. I've done this plenty of times, so it should be great, okay? So while you're kind of just hanging out and getting yourself ready mentally, I'm going to kind of gather my equipment and get set up, okay? All right, thank you, sir. All right, so first things first, I'm going to get a little drape here. Especially if you're putting an NG tube in for decompression, your patient has a bowel obstruction or something like that, more than likely they're vomiting. And also more than likely when you go to put this tube in, you're going to get a lot of stuff out. So having the patient draped would be a good idea. We also are going to have a little cup with a straw that the patient can use to swallow. In real life, I usually do have a second person here with me. Number one, to encourage the patient, and number two, to hold the cup of water for them. For psychomotor purposes, since it's just going to be you and I or your instructor and you can just set the cup there and say, I would have that ready to go, and I'll tell you when to swallow. Also in my kit, I have two different types of tubes, and you'll be learning all about these in the class portion of lab. But this one right here is a Salem sump tube. How do I know? Because it's got the little blue port. And Salem sumps are always used for decompression because if we inject air into this blue port, when we hook this tube up to suction, it prevents it from adhering to the wall of the stomach, which is great. So Salem sumps are typically used or almost always used for decompression, and they could be on continuous suction with this. Sometimes I've seen these be put in for decompression, the patient's doing better, and then we begin to use it for feeds. That is not uncommon, it does happen, but I wouldn't say that's most frequently how it's used. The other tube we have in here is just a solid straight tube, and this is called a Levine tube, like Adam Levine, you know, okay? This is used for feedings, okay, or giving medications. We don't typically use this for suction. However, if we do use it for suction, it must be intermittent suction. Can't be continuous suction because there is no air port to inject with air to keep it from adhering to the wall of the stomach. So Levine tube is used for feeds and meds or intermittent suction. The Salem sump is typically used for decompression, can be used for continuous or intermittent suction, may sometimes see it for feedings, but that's not usually our go-to. So if I give you the scenario in psychomotor that your patient has a bowel obstruction, I'm going to recommend that you gather the Salem sump tube, okay? So I went to the supply room and I got myself a Salem sump. Since my patient has a bowel obstruction, these come in like a nice little package. So I have that ready to go. I also am going to get my lubricant, some tape, and some pH strips that I'll need here in just a moment. I'll show you what that's for. So part of getting set up is to get your tape ready, because we're going to need a piece of tape to secure the NG tube to the patient's nose, as well as a piece of tape to secure it to the patient's gown. And I have found that when you get this tape ready ahead of time, number one, it makes your life easier, and number two, you don't forget. Also, I call, a student told me this one time, I thought it was so cute. You're going to kind of split this tape in half, and they said make it a pair of pants. Isn't that cute? Looks like a pair of pants. Okay. The pocket part is going to go on the patient's nose, and then these pant legs are going to wrap around the tube. So you can go ahead and get that done and set up ahead of time. going to do is I'm going to measure, and I'm also going to ask my patient about some of their past medical history. So, Mr. Smith, have you ever had any facial reconstructive surgery, esophageal varices, bariatric surgery, any kind of like facial trauma or things like that I should be aware of? No? Okay, good. I'm going to take a pen light. I'm going to shine it in each nair. Also maybe look in the back of the mouth. Everything looks good and clear. To me, Mr. Smith, do you have a preference on which nostril you would like me to put this in? You want to see which one feels more clear? Yeah, that's a great idea. Okay, the right nair, I like it because I'm over here, and that'll be great. Next up is I'm going to measure. So I'm going to measure from the tip of the nose to the earlobe. In case you're not familiar, this is your earlobe down here, all the way down to the patient's xiphoid process, which is right about here. Now, many of these tubes now in the hospital have centimeter markings on them, but if they don't have centimeter markings on them, no big deal. I have all this extra tape over here. So I'm going to take my strip of tape, and I'm going to mark where I measured to. The purpose of this measurement means that's how far I should be inserting the NG tube in order to get the tip of this in the patient's stomach. Okay, so that's why that measurement from the tip of the nose to the earlobe to the xiphoid process is so important. Okay, and that's why if we had a bariatric surgery patient, that might not be accurate because they have a smaller size stomach. Once I've measured it, now I'm going to go ahead and get a new straw. Sorry, Mr. Smith, I knocked your whole cup of water over.
There you go.
Okay, I'm going to wash my hands. Go ahead and put some clean gloves on in case, you know, Mr. Smith vomits or there's some gastric secretions happening here. And then I'm going to lubricate my catheter. This is your lubricant. It's usually blue in a little bottle like this in each basket. So I'm going to just dip the tip of my tube in there, and then you can kind of like smooth it down your NG catheter just like that. Okay, more lubricant the better. You don't want it to be too much, but lubricating it is going to help this go down nice and smoothly. On the end of your tubing, you want to either have a plug, or if you don't have a plug, you can use your syringe. So you could have this plugged in here to keep stuff from coming back out at you. And I promise you, if you're putting this in for decompression, stuff is gonna come, okay? So I'm gonna use the syringe. It's just gonna make my life easier, and so I'm gonna have it set up just like this. Okay, now this is your patient's time to shine, okay? So we wanna be very encouraging, let them know they can do this. And for the insertion and advancing of the tube, we have some specific positions we want the patient to be in. When we insert the tube, we want the patient's head to kind of be back like it is, looking or sniffing the air, they say, so that we can get the tube in. Once the tube is in the back of the throat, or which would be the measurement from the nose to the earlobe, now it's in the back of the throat and we want the patient to swallow. So you can kind of hold it right where that marking is, or if your tubing has the centimeter markings on it, you can eyeball it. It's usually about 10 centimeters. So when I get to 10 centimeters, that's the time that I want the patient to tuck their chin, take their drink of water, and swallow, swallow, swallow. This is when we are being their biggest cheerleader. On these mannequins, in these labs, they are not built exactly like humans. So if you're trying to advance the tube with the head up like this and it won't go, it's fine. It's because of the mannequin. Just allow the head to go back and advance the tube. Also, their bellies are not quite anatomically correct for this measurement. So don't be surprised if you can't get the tube all the way to this tape marking. In psychomotor, we just expect that you verbalize, I would insert the tube all the way to my centimeter marking or where my tape is. Okay? And you'll see how this happens here in just a minute. I don't know what's going to happen. I can't wait. Okay, so first, Mr. Smith, I'm going to have you tilt your head back. You're doing great. I'm going to go ahead and insert this in your left nair to about 10 centimeters. Now I want you to tuck your chin and swallow. Swallow, 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 swallow. See how quick and steady I'm moving this? And I'm going to insert it all the way until the tape. Once it's in place, I'm going to take my little pair of pants, put the pockets on the nose, and then I call this candy caning it, where you take these little pant legs and you kind of wrap it around the tube. And do another one this way to secure the tube. It's not the prettiest looking thing, but it holds it in place. You can also take another strip of tape if you'd like. So I guess you realistically could have had 3 pieces of tape. I don't know where the end of this is, but you could take another little strip of tape, put it down here, and then actually tape the tube to the patient's gown. So if it were to pull down here, it would pull on the gown and not the patient's nose. So just another thing that you might see in the hospital as a tip or trick. Okay, now that I have the tube in what I think is the correct place, I'm giving the patient some time to recover. He's probably got tears running down his face, and it's not a great time, but he's going to be feeling better soon. Now I can check placement of the NG tube in a couple different ways. The most reliable way is to get a chest x-ray. So I'm going to call the doctor, get an order for that, or some places have like a standard order when you place an NG tube that the nurse can call for an x-ray. Some places don't have an x-ray. So that's why we're going to go over what is the most reliable to the least reliable way to check for placement. So number 1, get a chest x-ray. If that's not available and or I want to do a second check, I can check the pH. So how you do that is with your syringe attached, you're going to pull back and get a little bit of what we call residual or gastric contents. Once you get that drawn up, you're going to pinch your tubing, take your syringe off, squirt it into your little medicine cup. You just need a drop or 2. I mean, really just enough fluid to be able to test it. Then you're going to take one of your pH strips and dip it and check to make sure that your pH is less than 4. Okay, and it is less than 4. Always check your ATI to see what they say. Okay, so pH is low. My chest x-ray confirmed the tube is in the right place. All good signs. Also, when I get a chest x-ray at this point in time and it says the tube is in the stomach, I can look at the centimeter marking and know shift to shift, this tube should be at, let's say, 56 centimeters. If your tube doesn't have centimeter markings on it, which most of them do now, but you never know where you're going to work. You might be working with some old school equipment. You can take a tape measure and measure the length of the tube that is out of your patient, okay? I wouldn't say very often you would have to do this, but if you do, now you know, okay? And then you would mark how much of the tube is on the outside of the body because you can't see what's on the inside. Okay, so centimeter marking I would say is the 3rd most reliable. X-ray, pH, centimeter marking, and then the least reliable, but a way you can check for placement is the whoosh test, okay? Students love to do this because it's fun and it's cool, but it's the least reliable because if you inject air, you're putting basically gas in your patient's abdomen. So, and if you're doing it a lot because you think it's cool, you're putting a lot of air in there. And sometimes when you do that whoosh test and then you listen for bowel sounds, you've created sounds in there that maybe don't really exist. Here's how you do the whoosh test. Draw up about 20 milliliters of air, or so, 20 to 30. Hook it up. See how every time I disconnect, I have this tube pinch? That's very important. If you don't, gastric contents is going to come back out at you. It's going to be a hot mess. You do it once and then you never do it again. So I'm going to take my stethoscope. And you guys all know where the stomach is now, which is in the left upper quadrant, right? So I'm going to listen. This guy's got like a 6-pack. I'm going to inject air in the left upper quadrant and listen for that whoosh sound. You will hear it. Maybe not on these mannequins, but definitely in real life. Okay, so that's my 4th, but least reliable way to check for placement. So now I know the tube is in the right place. My patient did great. I'm going to mark what type of tube, Levine or Salem, what size tube, which will be on the package, which nair the tube is in, and I guess how the patient tolerated it would be cool. Oh, and the centimeter marking. See, I caught myself. Okay, then we're going to plug this guy up. Then for your next 2 skills that you're going to do in psychomotor, you're going to be working on what we call what looks like a peg tube, okay? It's this really fancy Tupperware bin that is basically mimicking the patient's stomach, and this looks very much like a peg tube or a gastric tube inserted right into the patient's stomach. So we just don't want to be putting a bunch of fluid into these fake bellies because they get moldy and nasty. So our next skills we're going to do this way. So I'm going to wash my hands again. You can, in psychomotor, if you want, you can pretend like it's a new patient, or you can pretend like you're working with the same guy, like I've got it in. And now I have an order to irrigate, which is not unusual. Many times the patients will have a standing order to irrigate the NG tube that's hooked up to suction once a shift. Or you can irrigate to troubleshoot complications. So if he was vomiting with the NG tube in, there was low output in the canister looked clogged, or the tubing looked clogged, all indications that I might want to irrigate. So for irrigation, this is very important. You're going to choose normal saline. Okay, this is literally like an unclogger. You're going to use normal saline. You also don't need very much, like 20 milliliters is fine. I always pour my solutions into these little graduates because I know the syringe can fit in there. It can't fit in this one, right? So I always pour it in here and then draw it up. So I'm going to draw up 20 mLs of normal saline. I'm going to hook it up to this little tube here. I'm going to go ahead and kink it anytime I'm disconnecting. And then I'm going to inject or insert my 20 milliliters of normal saline. This is also very important. For irrigation, you're going to put that solution in, but the whole purpose of it is to unclog the tube. It's not to give the patient something, it's to fix the tube. So after you inject the normal saline, then you're going to pull back and withdraw what you put in. If you put in 20, you should get out 20. If you're getting more than that, then you have to document some as output. If you get less than that, then you have to document some as input. So if you want to make your life easy in psychomotor, you can just say, I put 20 in and I got 20 out, okay? Once you take it out, then you have to discard it, okay? Meaning it's literally going to go in the sink, a graduate, it's going to be disposed of. I'm emphasizing this for a reason because when we get to our next skill, it's going to be a little different, okay? So for irrigation purposes, you're going to choose normal saline, you're going to insert it, you're going to pull back what you put in, and you're going to discard it. Okay? Now, you can certainly check for placement during this process, but you did that when you put the tube in, and quite honestly, if this tube is being used for decompression or suction, you're going to see it in the tube. It's going to be very obvious to you that the tube is in the right place. Okay, so that's irrigation. That was great and wonderful. I'm going to go through a lot of gloves here, I guess. Okay, I'm going to wash my hands. And now we're going to have to kind of tell ourselves this is a different scenario because now we're going to have a feeding tube, peg tube that is going to be used for feeding and or medication. So for psychomotor purposes, you're either going to be doing feeds or meds. The reason we're not having you do both is because the skill is very similar for both steps. Let me clear up some of my stuff here. Okay, but to get started, there's a couple things I have to do first. I'm going to wash my hands again. If I'm giving feeds, we'll do feeds first, I'm going to check my doctor's order. So I'm going to make sure I have the right formula, ensure the right calories, all of the right components of my feeding order. You'll usually find this under the diet order. It'll say like 1 can of Ensure at meal times and bedtime with so much of water. Okay, we'll tell you that in psychomotor. We'll give you the doctor's order. So I'll say it says 1 can of Ensure with 100 of water is my doctor's order. I've checked it. I've gathered my supplies. Great. Now I need to do some assessment of my patient first. So the very first thing I'm going to do after I wash my hands, put gloves on, tell Mr. Smith I'm back again. This time I'm going to give you some feeding through your tube. But before I do that, I want to listen to your bowel sounds. This is very important. If he doesn't have bowel sounds, am I going to give this feeding? No, because bowel sounds mean there's peristalsis. And if there's not peristalsis, I don't want to give this, right? So you're going to check bowel sounds under the gown in all 4 quadrants, making sure that you hear active bowel sounds, which I do. Great. After I check bowel sounds, then I'm going to check placement. Number 1, chest x-ray. Number 2, centimeter marking. Number 3, number 1, chest x-ray. Number 2, pH test. Number 3, centimeter marking. And number 4, the whoosh test. Okay, if you demonstrated that in the first skill when you put the tube in, you don't need to do that again now. I've seen you do it, so you just verbalize it. I would check placement again and these following ways. But there is an additional step you have to do here, which is called checking for residual. So now you're going to take your empty syringe with your plunger in, kink your tubing, put your plunger in, and you're going to pull back and check residual. This literally means how much gastric contents is sitting in the stomach. It shouldn't be a whole lot. In fact, we want it to be less than 250 to 500, meaning if it's 250 to 500, that's too much. You're gonna pull back and check residual. It should be low, usually like less than a syringe. You're gonna know when it's a lot because after the syringe fills up with gastric contents, you're gonna have to squirt it into a graduate, hook it back up again, and draw back more. It's gonna be like the grossest thing you've ever done. So pull back, check residual. In psychomotor, it's not gonna be a large volume, okay? It's probably gonna be like 10 to 20. This is important. After you check residual, after you see how much gastric contents is in the stomach, you have to put it back in. If you took all that gastric contents out and left it out, you are gonna totally disrupt the pH and electrolytes of your patient's stomach, okay? So draw back residual, it's about 15 milliliters, okay? Put it back in, no problem. If the residual was very high, like let's say it was over 500, am I gonna give a feed right now? No, that means the patient's stomach is too full. So what I would do is wait about an hour, reassess residual. If it's still high, over 500 an hour, then I would let the physician know, hey, I checked residual this morning, it was high, I tried to get an hour later, it's still high, what do you want me to do? They may reduce the frequency, the volume, etc. That's kind of their call to make. Okay, so with all that being said, his bowel sounds were good, placement was good, residual was good, I'm ready to give the feed. I've checked my order and verified that everything was correct. I know I'm giving a whole can of Ensure and I'm giving 100 of water. So I'm gonna go ahead and pour that now. Good. And then just to make your life easier, this little tip, you can actually take the plunger out of the syringe and then you can pour your feed, and you can do this for your medications by gravity. So I'm gonna hold my syringe just like this. I always say, I feel like the Statue of Liberty. And then I'm going to pour my water first. Okay, flush the tube, make sure it's working. Could you imagine if it was feed in here and then we realized the tube was kinked or clogged and we got tube feed everywhere? Gross. Once that's all the way through, go ahead and kink your tube again. And now I'm gonna pour my feed. Now keep in mind, it doesn't really go until I unkink the tube. If you're really good and fast, you can leave it just like this and just pour as gravity drains it. You see this? Oh man, look at that scale. If it's draining really slowly, you can add a little water. I don't know about you, but I drink when I eat, so we can mix the feed and water as long as we're staying within the doctor's order. Now I'm gonna finish the rest of my feed. How you doing, Mr. Smith? Everything's going great here. Finish it up with water, okay? So start with a flush, then your feed, and with a flush, okay? And then I'm going to go ahead and plug this tube, and I'm gonna let Mr. Smith know, hey, while your stomach is digesting the tube feeding I gave you, I want you to stay sitting up, preferably in high hours, as high as you can tolerate for the next 30 to 60 minutes to let that all digest, okay? You feeling all right? Good, great. Okay, that was feeding. Next skill would be medications. Now this one does tend to get a little time consuming, so I'm gonna do my best to be as efficient as I can. Oh, I forgot to mention something, whoops, really important, which is when giving feed or meds, I get a new syringe, of course. When giving feed or meds, you wanna choose sterile water, okay? Because we're actually giving it to this patient. Like, it's going in and it's staying in. I don't know about you, but I drink water. I have never drank sodium chloride in my life, and I don't plan to. So sodium chloride or normal saline for irrigation, water for feeds and medications. If you grab the wrong solution in psychomotor, I can't tell you what's gonna happen, okay? But it probably ain't gonna be good. Okay, so for medications, I'm going to wash my hands, and I'm going to verify my doctor's order. Of course, you guys would always do that. I'll put this down for a minute. And I'm gonna make sure that this medication can be crushed. So in psychomotor, you may wanna tell me some medications that can be crushed, like capsules, hydrophilic medications, extended release, enteric coated, etc. So long as the medication can be crushed, you're gonna put one of these in your little pill crusher. And you're gonna crush it. This is what takes time, okay? It's very fun when you're practicing. And psychomotor is kind of nerve-wracking because it takes time, you're getting nervous. But we're gonna crush this medication up as much as we can. And once it's all crushed up, I am going to pour the contents into this little cup. Okay, I'm going to do the same thing for this next medication. Crush this next pill up. Get my next little pill cup. And pour that in the medicine cup. Now, in real life, you're probably going to have like 5 to 10 meds. For psychomotor, you'll probably just have 2. Okay? So I have my 2 medications. Now, I need to dilute these and kind of mix them up with some water. So what I suggest you do is pour your water into this graduate to however much you think you're going to use. I would say when I take medications, myself, I use a glass of water, which is 120 milliliters. So if you want to pour 100, that's fine. I wouldn't pour it out of here because you can't see just from looking at this how many milliliters it is. If you pour it in here and you have 100, no matter how you distribute this, it's 100, okay? As long as you use everything that's in here. So now I'm going to pour a little bit of water in my first pill cup and a little bit of water in my second pill cup. I mean, you should feel like a really cool like chemist or chef at this point. Mix this medication up with the water. Mix this medication up. Okay, this looks pretty good. Okay, now you have to remember your steps for your feed. It was just like your feed. So first thing I'm going to do, after I've checked my order, checked that my meds can be crushed, all that good stuff, I'm going to wash my hands, explain to Mr. Smith I got your morning medicine here. I've checked to make sure that they are all within the doctor's orders and that they can be crushed and given through your tube, and they can. So we are good to go. I'm going to first and foremost check bowel sounds. Same thing with your feed as your meds. I want to make sure he's going to be able to digest these medications. So I'm going to listen under the gown, all 4 quadrants. He has active bowel sounds. Then I'm going to check placement by the chest x-ray, centimeter marking while I'm here. I can even check the pH. Remember, hooking this syringe up and drawing back. Also, while I'm checking pH, I'm putting a little bit of it in here. Y'all remember, right? Dipping my stick. I could also check residual, right? You still have to check residual for your feed as well. Should be less than 250 to 500. Then I put the residual back, okay? So we'll say his residual was 15. I checked the pH, it was 4 or less. Everything is good to go. I can give my feeds. I guess I would have gloves on before I was touching this tube. Wash my hands, put gloves on, and then check residual and all the things. All right. So I'm going to take my syringe off. I'm going to pull my plunger out. And then if you guys remember, start with a flush, right? So I'm going to pour my saline in, my water in first. Let it drain, make sure the tube is nice and clear. It is, great. Pinch it back up. Now I'm going to give my first medication. And watch it drain. This went really smoothly, but if you feel like there's a lot of extra medication stuck to your cup, just pour a little more water in there. No big deal. Get the rest of your medicine in there. After all of your first meds in, go ahead and take some flush or some water, because you want to flush in between your meds. And then you can do your second med. Good. And then you're going to finish with a flush. Okay? So flush, med, flush, med, flush. This is a really nice bonding time with your patient, honestly. When you become really proficient in this skill, you can do this and talk to your patient. I'm talking to you, so I'm not talking to him very much. But it's a really good time to talk and connect with your patient. After the medications are in, of course, I've documented them in the MAR. I'm again going to tell Mr. Smith, while those medications are being digested, I want you to stay sitting up for the next 30 to 60 minutes. Think you can handle that? Okay, great. Okay, that is feed and medications. The very last skill, probably the easiest one, is removal of the NG, and that is a very happy day. Everybody likes when an NG tube comes out. So first and foremost, I'm going to come in, wash my hands, put clean gloves on, explain and introduce myself to the patient. So Mr. Smith, I cannot believe a week ago I put this tube in, and now I'm back today and we get to take it out. This is a great, great day. So this is going to be a lot less painful than it was going in. In fact, I only need you to do one thing, which is either hold your breath or breathe out. That's all I gotta do, okay? And then the tube will come right out. It'll be a piece of cake. So first thing I'm gonna do is, on the end of the tubing, I'm gonna hook up my syringe with about 20 mLs of air. You see that? Hook my syringe up, and then I'm gonna go ahead and inject 20 mLs of air. That's gonna prevent any, or clear any gastric contents from the end of the tube and prevent aspiration if he were to inhale when I was removing the tube. I'm gonna go ahead and drape him just in case he starts to gag, or, you know, who knows, maybe some, you know, secretions come out. Then I'm gonna go ahead and take this tape off. Okay, two really important parts of this skill is making sure you inject the air bolus and having the patient exhale or hold his breath on when you remove the tube. So Mr. Smith, on a count of 3, I'm gonna remove this tube and I want you to hold your breath. Okay, ready? 1, 2, 3, hold your breath. And then you should remove the tube in kind of just one smooth motion. Provide some nasal care to the patient, even oral care. Make sure his nose is clean and dry. He's going to want a tissue as soon as this tube comes out, so maybe even have some tissues handy for him. One last thing I did want to mention about the Salem sump, and we will cover this in lecture, is the blue port is where you inject air to prevent this tube from adhering to the side of the stomach. But when you irrigate the tube, so that was the second skill we did, after you irrigate, you would inject the air bolus through the blue port before you hook this up to suction. So again, we'll emphasize that in our lecture content. You don't necessarily need to demo that for psychomotor, but I just wanted to mention it while I still had the tube out. Okay, now's your time to practice. You guys will do great, and look forward to seeing how y'all do.